What's going on, my healthcare brothers and sisters? I hope that you're having a wonderful day. We're continuing on with that fluid movement discussion, and we're going to be talking about hypotonic solutions. So in order to understand fluid movement, we really have to understand a solution's tonicity. So tonicity is measured as the effective osmotic pressure gradient, that is the water potential of two solutions separated by a semi-permeable cell membrane. So concentrations of solutes are dissolved in a solution, which determines the direction and extent of diffusion. So fluid tonicity is the comparison of IV fluids to our blood plasma. So if we have an IV fluid that is less concentrated than our blood plasma, then we have a hypotonic solution less than 250. If we have an IV fluid that has a similar concentration to blood plasma, then we have an isotonic solution. That's usually between 250 and 295. And lastly, if the IV fluid is more concentrated than our blood plasma, then we have a hypertonic solution that is greater than 295. So hypotonic solutions, it's when a solution contains a lower concentration of salt or solute than another more concentrated solution, making it a hypotonic solution. So what does that mean? The concentration of a lower osmolality of blood. So with osmotic pressure inside the cells being higher than the osmotic pressure outside the cells take in water in an attempt to equal out that osmotic pressure, causing them to swell and even burst. So our normal osmolality of blood is between 270 to 295. Something that's big to remember when it comes to your NCLEX is that cells can swell, making them a hypo, H-Y-P-O, also known as hippo is what we call it, solution, just like our hippos. Hippos love water, and cells in the presence of a hypotonic solution also loves water. That's what causes them to get all swollen like our hippos and eventually burst. So examples of hypotonic solution include half normal saline. It has an osmolality of 154. We also have 1/3 or 1/4 normal saline. We have 5% dextrose in water when it's inside the body. So if you haven't reviewed my isotonic solution video, I highly recommend that you watch it because we go into further discussion about why D5W is isotonic inside the bag and hypotonic in the body. It has an osmolality of 252, and it's not really recommended for diabetics with hyperglycemia or an increase in intracranial pressure. We have 2.5% dextrose in water as well as sterile water. The sterile water has an osmolality of 0. So let's talk about fluid shifting when it comes to hypotonic solutions. So we know that they have an osmolality of less than 250. So how does fluid shift? Well, fluid is going to shift out of the blood plasma and into the cells. That's done through osmosis. So water moves from that lesser concentration to that higher concentration to dilute those solutes, right? So because that fluid shifts from the blood plasma into the cell, we know that it's going to cause our cells to get really big. They're going to become very swollen, and they can eventually burst if they have too much of a osmotic difference between the cell and the fluid. So what are some indications when we're giving hypotonic solutions? Well, one is cellular dehydration. So with cellular dehydration, it causes the cells to shrink because all the solutes are now on the outside of the cell, such as our sugars and increased sodium, causing a hyperosmolar state in the blood. Hypotonic solutions are beneficial by causing that fluid to shift back in the cell. This is when we would really want to give those hypotonic solutions, when we need to rehydrate those cells. And you're going to see that when it comes to our diabetic ketoacidosis patients, that's our type 1 diabetics, or our hyperosmolar hypoglycemic non-chaotic syndrome, HHNS, type 2 diabetics. We also can give it when it comes to our hypernatremia patients to help kind of dilute some of that solute. Contraindications when it comes to hypotonic solutions include hypovolemia. The problem is related to a loss of blood volume in the intravascular space. So Hypotonic Solutions will actually make the hypovolemia worse by shifting the fluids into the cell. So we don't want to give a hypotonic solution when we have a hypovolemic patient. We really want to give an isotonic solution for that. When it comes to burns, again, that can increase that hypovolemia. We don't want that. We also don't want to give it when we have an increased intracranial pressure patient, because it can cause cerebral edema by shifting the fluids into the tissues, which will only increase that swelling, leading to a potential for increased risk of seizures with our ICP patients. So what are some nursing considerations that we need to consider when giving hypotonic solutions? Well, one is we don't want to give this via rapid infusions. Why? We want to give this slowly to prevent cellular edema and decrease the chances of cells bursting open if we're giving it too quickly. We also want to make sure that we're not giving an excessive amount of these solutions, because that can lead to fluid depletion inside the blood vessel, causing hypovolemia. Like we talked about before with hypotonic solutions, the solution is shifting inside the cells. So if we just got fluids that are continuously shifting inside of our cells, one, they're going to burst open, and two, we're going to have that depletion inside the blood vessel because it's not where it's supposed to be. And lastly, we want to look for hypovolemia signs and symptoms, because it can cause hypovolemia due to the shifting inside the cells. So we have tachycardia as always an early sign that we've got some hypovolemia occurring. Decreased blood pressure. You also might see cellular edema as well as cell damage. So it should not be given when we have a patient that has liver disease, trauma, or burns, because we want to make sure the fluid is where it's supposed to be. If we start to see cell damage or cellular edema where they're bursting open, then you're going to start to see those higher potassium levels start to creep up. We talked about our potassium is an intracellular cation. So if we have it bursting open and it's not able to get inside the cells, it's just going to sit in our serum inside of our blood plasma, right? So when we're drawing up our labs on our patients, you're going to see that potassium slowly start to rise as those cells continuously burst, becoming damaged, and ultimately that could be very bad for our patients. I hope that this video was helpful for you in passing your nursing exams like a boss. If you have any questions, please feel free to leave them down below. I love answering your questions. Make sure that you follow me on my social media. I'm on Facebook, Instagram, and Twitter, as well as here on YouTube. Make sure that you subscribe as well as like this video. I also have a website at www.nursecheung.com where I will have NCLEX style questions as well as additional resources with each of my videos. So make sure that you check that out. But until next time, I hope that you're having a wonderful day, and I will speak with you all again soon. Bye!